All right, why don't we get started? Welcome everyone to another edition of Tumor Talk. We're here today with a return guest, Dr. Jacky Yeung, discussing really how we can use connectomics to help in our post-operative patients. We've talked about this a lot recently in terms of what it offers: pre-operative guidance, planning of a surgery, kind of anticipation of cognitive, potential cognitive deficits, but we haven't seen yet how we can use this in the post-operative setting. And so this is I'm very excited about today's session. Jacky, why don't you go ahead and introduce yourself and we can get started.
Sure thing. Randy, Jason, thanks for having me being on Tumor Talk to share our latest publication in Journal of Neuro-Oncology. It's always a great pleasure and honor to publish there. And let me introduce myself. I'm Jacky Yeung, currently an assistant professor of neurosurgery at Yale University. And a lot of the work that I'm going to be presenting today is in collaboration with my team in Sydney, especially with Dr. Michael Shukru and Dr. Charlie Teo and the Singulum Clinic. So I am ready to share the screen when we are.
Go right ahead.
Okay. All right. Everything's good?
Looks great.
Okay. All right. So the title of the paper that was published is Improving Quality of Life Post-Tumor Craniotomy Using Personalized Parcel-Guided TMS, Transcranial Magnetic Stimulation. I'll talk a little bit about what that is. Not all neurosurgeons know about it. And in fact, I didn't even know about it 2 years ago before I was exposed to it. For disclosure, I have no commercial support for this presentation, nor do I have any financial relationships with any of the products or clinics in this presentation. So I think it's no strange news to the audience of Journal of Neuro-Oncology that patients with brain tumors, they have a hard time going back to normal life after surgery. And it is no surprise we go in there, perform brain surgery, especially intraaxial surgery, and they just have problems being themselves. And a lot of them are outside of the realm of motor deficits, language deficits. A lot of them have to deal with more subtle things, but very, very much affecting their lives. These things can go from depression, anxiety about their well-being, executive function, even being able to pay off their debts or write a check. And we know that actually in these previous publications in Journal of Neuro-Oncology that we oftentimes have trouble localizing which anatomical part of the brain is responsible for each deficit. And we know that patients with postoperative depression actually have shorter survival. So this is not something that just affects quality of life. It actually affects the performance of the patient and subsequently how they fare with treatment, etc. So our job as neuro-oncological surgeons and actually as caregivers of for patients with brain cancer is to try to achieve this very popular term now, oncofunctional balance. So on the MRI, we want great resection or great resolution of a tumor mass. But at the same time, we have to think about at what cost. So for the patients, we want to maintain their functionality as much as possible as a human being. So as Randy had mentioned, we now have the tool to map out the brain preoperatively to visualize different functional networks surrounding a brain tumor so that we can actually plan a trajectory that would hopefully avoid those major networks, or sometimes actually be able to intentionally intrude on those networks with hopes of there being some redundancy. But what happens when there's no redundancy? And what happens when a patient suffers neurocognitive psychiatric deficits after brain surgery? Can we actually do something about it? Can we augment the brain connectome for what we now call interventional neurorehabilitation outside of the usual realm of physical therapy, speech therapy, cognitive therapy? In a previous published paper, we've already looked at how we can, by using brain mapping and looking at the connections between each brain parts, or how we call it parcellations, how they communicate with each other, and then compare them to a cohort of quote unquote normal healthy subjects. And then from that point on, we'll be able to see, okay, in our patients, there are indeed parcellations that might be hyper communicating or hypo communicating via very sophisticated statistical methods, of course. And if we are able to identify those aberrant connections, then maybe we can do something about it. And what would that be? In this paper, we talked about transcranial magnetic stimulation, which we have shown to be able to improve language deficits and motor deficits. So what it is basically, it can be used via navigation, a magnet to induce an electric field to non-invasively stimulate a certain part of the brain. So at Singulum Clinic, which is in Sydney, Australia, we asked the question, was personalized repetitive TMS treatment associated with improvements in functionality and quality of life? We have the basic evidence that, hey, it increases the functionality, the strength, or perhaps speech performance, but does it actually make a difference? If a patient improved from 2 out of 5 strength to 3 out of 5 strength, truly there is improvement objectively, but what does that mean for their personal well-being? So we looked at our patient cohort retrospectively, and with an average follow-up time of about 2.5 months. We chose this minimum follow-up because this is a proof of concept study, and therefore we didn't have a control group, and we were very weary of placebo effects. But usually one would argue that placebo effects usually wanes after a month or so. So therefore, we're more confident about the lessons we've learned from our patients. So indeed, the take-home points from this paper is that the quality of life as measured by EQ-5D were significantly increased for patients after craniotomies and being treated with RTMS, whether they have motor deficits or in one patient who had severe depression. And the way that I looked at this is that it really should be bringing up more questions than answers. We know that it can enhance physical rehabilitation, not just motor function, language function, but it might even actually be able to help us enhance psychiatric illnesses as well. That is a direct result of brain surgery. So I always like to end up with this patient who's a 40-year-old mother of 3 children with a left temporal insular glioma that was resected. The patient's language was preserved. However, she suffered severe exacerbation of her depression such that she wanted to commit suicide after surgery. So with that in mind, we try to look at the networks that are heavily implicated in mood disorders, such as the fault mode network, central executive network, and the salience network. And then we identify areas that are miscommunicating with others. And it turns out that actually the treatment and targeted areas are away, for the most part, from the resection cavity. So one of the lessons we demonstrated in this paper is that actually, because the brain acts in networks, a lot of the issues can happen outside of where we operate. So long story short is that even 1 week after treatment, her depression significantly improved, measured objectively using Beck's depression inventory. So in conclusion, our paper talked about how we can use personalized brain mapping, connectomics, navigated repetitive TMS to treat and hasten neuropsychocognitive recovery after craniotomy. And this actually translated to improvements in quality of life. And all in all, this calls for larger studies and controlled studies in our community to really show that this type of approach is feasible and makes sense for interventional neurorehabilitation. Thank you.
Jacky, thanks so much. Yeah, I agree. I think, it's always kind of the questions that arise from studies like this. Number one, I want to congratulate you guys because I think it's a very novel concept. Neurosurgeons, I think, have traditionally always been the preoperative and intraoperative, domain. That's been our realm. And here we're able to dive into the post-operative recovery and possibly offer more, right? And get someone through not just their surgery and their diagnosis, but also their recovery and then their treatment subsequently. So that's an incredible, thought process, basically, a thought to go with. My main question here is, every thing you just described, every possible disorder or cognitive, whether it's depression or motor or language, that's a different area. How do you choose your target? This is obviously going to be patient specific, but is there some way to choose a target that you can use software, or is it intuition, or where it should be based on their deficit? How do you do it?
I actually love learning about this approach to postoperative recovery because it actually brings doctoring back. So to start off with, how do we select targets? I actually draw analogy from our functional and epilepsy colleagues, where they really talk about their patients in a hypothesis-driven manner by symptomatology. So I asked the patient in a very open-ended way, what's actually affecting them? So besides motor deficits, language deficits, how's their life going? And from that, we were able to pick out some of those cognitive deficits that we don't usually pick up in a normal postoperative visit. So after that, we start to diagnose them. And then we try to employ something that is really pioneered by our psychiatry colleagues called the transdiagnostic approach. Then we try to ascribe that kind of deficit or disorder to certain networks. And this is where we have a wealth of knowledge by our neuroscientist colleagues. They talked about different networks implicated in depression, anxiety, etc. Then, since we now have the tool to visualize and quantify the communications between any two networks, we then draw our attention to those specific networks that we suspect and hypothesize to be implicated in the patient's presentation. And then we can look at their actual communication, see if there are any basically hypercorrelations or hypocorrelations suggesting that they're not talking to each other properly. Then that's how we would land on a target for stimulation.
And do you believe, obviously we talked a lot about cognitive outcomes and especially psychiatric outcomes for the most part. But when it comes to something like a motor deficit, and I've read the paper out of Germany that I thought was very interesting, and I know some of the stroke data that they try to do with this in the past. But how do we bring back a motor deficit? Obviously, there can't be injury to the cortical spinal tract. It's got to be a different pathway of some sort, right?
Absolutely. So this study, I hope it brings excitement to the field, but there are some neurosurgical truths that will still remain. If you, as you said, sever the cortical spinal tract, this method is not the way for any therapeutic means. But a great example would be the SMA area or anywhere in the premotor areas. So if we know that we can visualize those networks, avoid them, or actually just very intentionally resect it while having some redundancy left there, then we can actually employ this technique to hasten and actually improve the recovery. So specifically, a great example would be trying to recruit the contralateral hemisphere so that the patients, in combination with active physical therapy, be able to improve faster. And that's pretty much the whole argument for it. So in the end, to answer your question, it goes down to the axiom of whether a brain part has redundancy versus essentiality. Essentiality being motor cortex, for example. Redundancy, great example, is the SMA. So that would be my answer to your question.
Jacky, this is a great and very provocative study, and that's why I liked it for Journal of Neuro-Oncology. One of many reasons why I liked it. Again, my hat's off to you. It's a wonderful study. For those who are on the audience and for those who will be watching this at a later point, can you speak a little bit more about the actual implementation of TMS for a patient and how, I mean, I would think it would be fairly easy to be integrated into rehabilitation therapies, but for those who may not be as familiar with it as you are, and can you speak a little bit about the facile nature by which this could be done?
Absolutely. So a lot of credit goes to Michael Shagru, Dr. Charlie Teo, and Jessica, actually, who collected the data for the study. So the actual implementation of the TMS, actually, we steal it from our psychiatry colleagues because they've been doing it for pretty much 2 decades now. The part that we are adding to it is by using the personalized mapping. So number one is after we see the patients, the logistics involve getting a resting state fMRI and also a DTI sequence with the MRI, and then of course process it using the software demonstrated in the paper. So afterwards, in terms of the logistics, I showed it in a short clip there. There are navigated TMS machinery out there that allows you to extract the exact parcel that you've selected, the area, and then input it so that just like our stereotactic neurosurgery, we can aim the magnet directly at the area of interest. So there are a few protocols out there, especially with our psychiatry colleagues, that really varies. Is it a week or is it a month protocol? There are different variations in terms of the frequency of stimulations. There are different forms of it. So long story short, that really there's still a bit of debate about what's best for each disorder. But after that, between stimulations, we try to take what we've learned from depression, the treatment of depression, meaning between stimulations, you can incorporate cognitive behavioral therapies as an adjunct. So in our case, if someone has a motor deficit, we try to incorporate interstimulation physical therapy as well, because in the end, we believe in neuroplasticity and trying to not make new connections, but rather wake up ones that were previously dormant but not active. So with adjunct therapies together, that's how we really get everything together as a package. It's a fairly complex process that actually was made easy by learning from our neuroscience colleagues.
But this is all, just to be
Yes.
clear, this is all done as an outpatient. This is something that is integrated much more easily into outpatient therapy and rehabilitation. So I think that's just so such a great design in terms of a tool that can be integrated into neurological rehabilitation for these patients. And then one other question, which is related to, as you sort of said, you're not necessarily trying to make new connections, although maybe you are, but but you're trying to sort of wake in existing connections. Are there connectome mapping studies that have shown in patients who have had the RTMS that there actually is some change that accompanies, maybe in a delayed fashion, on imaging these clinical improvements that you've demonstrated?
Absolutely. So I will clarify the statement. So it's not so much that we're just creating connections out of thin air, but as Dr. Shagru like to talk about it, our connections in the brain, it's one of the theory is that there are redundant connections, and usually in terms of brain connections, we go by efficiency. So the connections that are usually present is the one of least resistance. So if that one is gone, there might be redundant pathways that we can recruit. So that's just to clarify the first statement there. And in terms of actually, like, can you repeat your second question again?
Just in terms of the neuroimaging and connectome
Right. Right, an
correlates that
example.
may point to that may accompany these clinical improvements that are being manifested.
So absolutely. So we've previously published as well, and we're collecting more data on more patients with chronic strokes, actually. So patients who have had strokes 2 years, basically more than a year ago, when we typically think that they've really plateaued on conservative therapies already. So after treatment with this type of protocol, we perform repeat imaging, basically repeat mapping, and even just by looking at the DTI in itself. So, for example, 19-year-old female with chronic stroke with right upper extremity deficits, we can see definitely increase in number of tracks from the contralateral hemisphere. And this was accompanied by very objective right upper extremity functional score as well. So I would have to say the data is there, it is emerging, and it definitely needs to be accrued in a very systematic fashion.
I think that's the key part there, because you're talking about a procedure. It's barely a procedure. I mean, you sit on a table and magnets go around your head, right? That has a possible efficacy in not just brain tumor patients, but now you hit the nail. You got stroke patients, you got Alzheimer's patients, Parkinson's patients, anything where there is potential redundancy in neurologic function that can be strengthened. And hell, I mean, I'd like to sit in a chair and see if I could read faster afterwards, right? Or if I can think a little better afterwards. I'm not sure it's necessary, but it's possible, maybe, right? And so I think it's a burgeoning new field. I got to tell you, I've been very interested in this in a while. And there are roadblocks to getting it implemented. Psychiatrists who have these machines don't need an MRI in order to treat with TMS. They can treat based on depression, anxiety, just rudimentary kind of targets. And it's more sophisticated places that have adopted these navigated ones, which, when you're using an imaging-based thing like the connectome as it stands right now anyway, you really need that navigation. You need that MRI component. And so, it's either acquiring a machine yourself or figuring out another workaround for it that can be tricky. And then the data's just coming out. And so it's hard to sell people on something. The stroke data previously has not been super strong. There's a great randomized trial out of Germany that came out recently about motor strength returning and vascular injuries. And we obviously have your paper now that, like Jason said, is very provocative, but I think there's a big future here. And I'm super interested in it. I think it's a great thing to be, ahead of the curve on.
Yeah. So 2 comments on that. Number one is it's always a joke that TMS researchers, before they write a grant, they do TMS themselves to try to enhance some creativity. That's a joke in itself. I don't know if it's true.
I'm into it.
And number 2, I think in the end, as we evolve as a field, patient selection is going to be very important, some of which we have covered. People who have corticospinal tract damage. I mean, that's an issue of something that's essential that's been wiped out. So they would probably be bad candidates for any kind of trials or comparative studies later on. So I think as we move forward, as you have said, we have to really be able to stratify the patients based not just on their clinical presentation, but perhaps based on their connectomics. Yeah. So people who have specific connectomic changes and deficits, they should be grouped as one group of patients, not just clinical presentation.
I think it's so fascinating. We know that functional status after surgery is a prognosticator, right? And we know that when we do a surgery, we hurt someone, that we've taken away any benefit that surgery was really going to give them. And all of a sudden, you talk about oncofunctional balance. This tool has the potential, anyway. We need more work, but the potential to tip that balance back in the patient's favor. And so I think it's worth looking into and spending the time on.
Absolutely.
Go ahead. Were you going to say something, Jason?
No, I mean, I think that the potential applications of this are just so broad. I mean, it goes well beyond the neuro-oncological spaces you've indicated. Obviously, I think that there are tremendous neuro-oncological indications in patients who are recovering. And this concept is, again, when we think about the cost of recovery, is potentially so low compared to so many other things that we do. If it can either improve the rate of recovery of certain neurological functions or improve the extent or both, it truly would seem like this could be an incredibly cost-effective, low-risk approach. So that, I'm excited. Let's see where the science takes us. As you said, more studies to come, and we hope to hear more from the group.
Yeah, and certainly we're exactly looking at cost effectiveness, because that's the next step after quality of life changes. And does it make sense? Does it make sense for us as a society and as a community to move forward with this into learning more about it? So thank you so much for publishing this paper.
Oh, we can only hope there are going to be more. Keep them coming. And the high quality of science is so important to advancing the field. Thank you.
Absolutely. Jacky, thanks for being here. Jason, great to see you. I believe we're back next week. We've got a packed schedule in the next month or so. So thanks again, everyone, and we'll see you next time.
Thank you. Bye-bye.
Bye-bye.